in or watching this. Either way, I'm going to go through some slides that I've written for tonight. The first part is going to be dealing with erectile dysfunction. The second part with urinary incontinence, and hopefully it'll be interesting to everyone. As Carlos was mentioning, I do want to encourage people to ask questions. There's a chat box at the bottom. Please use it, and we'll try to get to everyone's questions. Excuse me. Sorry, let me put this on Do Not Disturb. Okay, there we go. So without any further ado, I'm going to share the screen with you. Let's see, we should be right. Oh, that's not it. What is it? Okay, can you guys? No, I think that's not wrong one. Excuse me. You can tell I'm an expert at sharing screens. Okay, well, hopefully that won't happen. I apologize. Okay, so as Carlos said, I'm a urologist. My practice is pretty much dedicated to issues regarding men's sexual dysfunction as well as urinary incontinence. And a lot of my men are cancer survivors, but we see other men as well who suffer from these issues. So this is going to be the title of this talk. We're going to talk first about erectile dysfunction, the causes and treatments. So this is what we're going to try to cover in the next few minutes: what it is, why do we treat it, who gets it, is it ever dangerous, what are the causes, how do we diagnose this, and then how do we treat it. So let's look at the definition first. So a lot of people think of erectile dysfunction as impotence, which is not a word I like. It means lack of power. We don't like that. And a lot of people think it's a total inability to have an erection, but that's not exactly the definition. It can be a total inability, that's true. It can also be an inconsistent ability or a tendency to sustain only brief erections. So why do we care? Well, this is a significant issue with quality of life. Gosh, I'm really having trouble here. Excuse me. Okay, there we go. It influences the general health perception of men. We know it's a big unmet medical need, and it may reveal other disorders that should be treated. And I'll get back into that, but sometimes erectile dysfunction precedes people knowing about diabetes or depression or high blood pressure, et cetera. When I say that it influences the general health perception of men, what do I mean by that? If you take two guys and they're in equal health, and one has erectile dysfunction, one doesn't, the one who has erectile dysfunction thinks of themselves as less healthy than the one who does not have it. So it is something that really does influence people and how they think about themselves. So why do we care about this? This is a quality of life issue, not a quantity. Most things in medicine are about quality of life. It's not really about how long you live, but how well you live. And medical care doesn't always have to center around prolonging life. You know, it's about making life worth living. Obviously, erectile dysfunction is incredibly important in terms of intimacy within couples, masculinity and the sense of masculinity, and so on. Okay, so who gets it? Turns out a lot of people get it. This is the largest epidemiologic study that has been done. This is kind of an older study at this point, but you can see, looking at this graph, that if you look at the age of the people who responded, and then how many people have some erectile dysfunction. That can be minimal, that's the red. It can be moderate, that's the sort of magenta, or it can be complete, that's the orange. And you can say that about 50% of guys at 50 have had some loss of function, 60% at 60, 70% at 70. And you can really see that it's the moderate and the complete erectile dysfunction that really is what grows over time. So you can think about 10% per decade of life. Okay, so what's the problem with this? The problem is that not many people actually seek treatment, and those who do seek treatment, they discontinue it once they start it. Okay, so why is that? Well, you know, there's lots of reasons, and here's just one of many studies that looks into this subject. So patients want to talk about their erectile dysfunction and their sexual health in general. And patients believe that their healthcare provider should inquire about these matters, but most patients, about 3/4 of them, felt undersatisfied by how their healthcare providers asked about it. Now, on that means that about only 1/4 of the patients reported that the physician or the healthcare provider made inquiries about this. Now, there's studies that show kind of the opposite. Why don't healthcare providers ask? And they say, well, they don't want to embarrass the patient. They don't know what to do about it anyway. And so basically you have sort of two sides where they really should be talking to each other, but they're not. Okay, so I mentioned earlier that erectile dysfunction can be an indicator of undiagnosed disorders. There are many, many, many studies that look into this. So I'm just going to highlight a couple of older ones that were really important. Here's one. This is at the United Kingdom. These are people coming to an erectile dysfunction clinic. You can see that about 40% of them had elevated lipids or cholesterol. And of those, 70% had never been diagnosed with that, meaning they were found to have the elevated lipids or high cholesterol because they came in with ED. Similarly, about a quarter of the patients had diabetes. 14% of them did not know they had diabetes. This is how they were diagnosed. Same thing with high blood pressure. Quite a few had high blood pressure. About 30% had never been diagnosed. So people show up with ED. It's like the canary in the coal mine. This is what they have. And then you find out that it's just kind of a manifestation of something a little more general that's going on with them. Now, why is that? Well, here's just a schematic diagram that looks at relative size. These are not the absolute sizes, but if you look at the blood vessels that are in the heart, so that's the second one here, or the brain, or down into the leg, and then you look at the penile artery, the first one, is much, much smaller than the others. And so if you have a problem that affects it, it's going to affect the penile arteries before it affects anything else. So this is just another picture of this. This is showing a picture in the heart, and you can see that yellow bit over there, that represents what they call atherosclerosis, or a plaque. And that's starting to maybe block off things a little bit, but you can see most of the blood vessel. But the same size plaque in the penile vessels is starting to really block the entire vessel. So that's really the issue. Now, diabetes is a particularly bad disease. Diabetic men are at higher risk of getting ED than most disease states. So I mentioned that quite a few men will present with erectile dysfunction and be diagnosed with diabetes as a result. That's about 10%. And if you look at how many guys get diabetes, well, a lot. And basically, if you're over 60, now this depends on how well the diabetes is controlled and lots of other things, up to 95% of those men have ED. So it's really, really common. Now, what are the causes in general of ED? Well, a lot of it is blood vessels. Blood vessels accounts for the vast majority of issues, and that can be flow into the penis, or it could be the ability of the penis to hold on to the blood once it's there. There are also neurologic causes like strokes or Parkinson's disease, spinal cord injury, and so forth. There's some issues with hormonal abnormalities. A lot of people are familiar with low testosterone. That's one of them. And then there's what we call iatrogenic, meaning it was caused by the healthcare system. Surgery is a big one. People who've had surgery for prostate cancer, or surgery for rectal cancer, or aortic aneurysm, things like that. And you'll see that a couple of these things, like diabetes, is listed in multiple places here because it causes multiple kinds of problems. This is just another way of looking at the same thing. You can see vascular, that's a big one. Medication, it's a pretty big one. Diabetes, very big one, and which of course crosses into different categories. And then there's a lot smaller issues from surgery, from neurologic causes, endocrine causes, and so forth. So prostate cancer is something that we see a lot because prostate cancer is very, very common in men, unfortunately. And when a man has treatment, whether it is surgery or radiation, less than 10% of people feel they are as good in terms of their erections after the treatment as they were before. So that's not very good, meaning that most guys do not preserve their function after they have treatment. They're alive, which is great, but they need to know that this is something that can happen. Now, of course, it happens over a different timeline. If you have surgery, then the sexual function drops immediately. But with radiation, it happens just as much, but it takes longer to get there because radiation acts more slowly. So are there any medications that cause erectile dysfunction? Yes, there have been over 200 medications that have been associated with erectile dysfunction. The medications that are used for high blood pressure, these are really, really common. These are common offenders, but also the antidepressant medications, some of the medications that are called anti-androgens, such as finasteride, which is used for enlarged prostate or for hair loss. some of the things that are used for acid reflux, and then of course, things that are more recreational things. So that can be cigarettes or any tobacco use, cocaine, marijuana, anything like that. So how do we go about diagnosing this? Well, we want to see how long the patient has had the problem and what is the specific thing that bothers them. We want to know about what's been going on in their life and their social factors. Are they in a relationship? Are they not in a relationship? Are they smokers? Are they not smokers? Are they having certain medical problems or not? We want to know if they still have erections at night. That doesn't mean they can have erections, when they want to, but at least it says the plumbing must be, okay if they're able to have nocturnal erections. We do a physical examination to make sure there's no obvious problems. And then there's certain kind of questionnaires that are very helpful to us. Medications. Most people are familiar with these. This is the cover of Time magazine. When Viagra came out, it was a huge deal, and it absolutely changed the way that people communicated about erectile dysfunction. This was in the late 90s. And these are the medications that have generally been used. The ones that are most common now are the generic forms of Viagra and Cialis. So that's sildenafil and tadalafil. Now, pills are not the only thing available. There are other kinds of ways of getting erections, and we're going to go into all these in some detail. So one treatment is do nothing. So what happens if you say, well, I'll just kind of see what happens if I just have erectile dysfunction? Well, it's a problem, because if you don't use it, you lose it. We are all familiar with what happens to muscles. If you stop working out, they atrophy. The penis actually doesn't just atrophy, it sort of starts to scar. And so if you look at a guy with erectile dysfunction, because they're not getting any blood flow into the penis at night, they're not getting any during the day either, they start to shrink. So they get shorter, they get narrower, along with their lack of function. So pills. Pills work well. This is just looking at Viagra, but you could substitute any of the pills for this and it would be about the same number. So if you say, how many guys get a better erection on the pills? Well, it's pretty good. So this is about 80% will say that it's improved. About a quarter, if you give them a sugar pill, will also say they're better. So there's a placebo effect, as there is for all sorts of issues we have, but that's okay. You can see the pills do work well. However, what this doesn't show is how many guys have an erection that's really satisfactory for intercourse. And that's not as good as 80%. We're going to come back to that, but it's not as good as this looks. Are there any reasons you wouldn't be able to take a pill? Yes, there are. And this is true with all of the pills. One of the things are nitrates. So those are medications that are used sometimes for people who have chest pain, and they can make the blood pressure drop very low. And those of you who are old enough to remember when Viagra came out, there were actually deaths after Viagra was introduced because of mixing these medications, and the blood pressure would drop too low. Now, there are some keys to using the pill successfully. Number one, they're not magic. They're more amplifiers. So you need sexual stimulation. All the normal things you do to get an erection, you still need to do with pills. There has to be foreplay and romance and so forth. It's better to take them prior to a meal or after a light snack so they can absorb well. And they also may not work the first few times. We have guys try them at least 6 times. Now, of course, you also want to make sure that it's not just taking a pill to cure problems that are caused by lifestyle, as it were. So if you're a smoker, you do a lot better if you stop smoking. If you are overweight, you do a lot better if you lose weight. If you are sedentary, you do a lot better with exercise, etc. Now, a lot of guys do have side effects from these, about 30%, but only about 5% stop the medication just because of the side effects. So they're well tolerated. So what happens if the pills don't work? And I'm going to come back to the data on this, but it turns out that about 50% of people who take pills ultimately are not satisfied with them. So that doesn't work for everyone. So one option is what's called a vacuum device. A vacuum device is not a medication. It's a plastic cylinder that you put over the penis, and you kind of create a vacuum, and it pulls the blood into the penis. And then there's a band that's kind of at the base of this cylinder that acts like a tourniquet to hold the erection. So there's no drugs, there's no pills, there's no nothing involved, just the device. So they do work, they work okay, but the satisfaction rates are terrible. So advantages, you use it when you want. There's obviously no side effects because there's no pills, and they're cheap. The disadvantages is everything else. They're cumbersome. The erection is sort of unnatural. It's sort of colder and maybe the color may be weird. You can get bruising. You kind of have to be in a stable relationship. This is not good for single guys because there's just too much stuff that's involved. You can see all the different side effects that are here. So unfortunately, satisfaction is very low. This is something that might be a bit better, and this is commonly used. So these are injections. Now, this is a tiny needle, like the size of a tuberculin needle, if anyone's familiar with that, or something you would use for diabetes. And it's a drug that goes directly in the penis, which makes sense. If you have a problem with the penis, you should put a drug in the penis. And unlike a pill, which goes everywhere in your body, including your penis, and you get side effects from, since this goes directly in, there aren't any real side effects other than the penis itself. They give a natural erection, and they work quite well. About 85% of guys can find a dose that generally works for them. So the advantage is that they work well, and the erection's natural, and they still have good sensation. They can have good ejaculation, and they're kind of discreet. This is a small needle. You could kind of sneak off to the bathroom and do this, and your partner really wouldn't know or care. The disadvantage is that it's a needle. It's a weird thing. People are in the mood for intercourse, and so they stick a needle in their penis. It's just sort of an unnatural sequence. Of course, they can get bruising. They can get these prolonged erections, the erections that last 4 hours or more, which is actually a huge problem if it happens to you. You can get scarring. It can be painful. You can imagine if patients either have poor eyesight or are quite overweight, it can be very difficult for them to do because they can't see the penis, and so they can stick anything down there. Definitely requires training, definitely requires follow-up, and lots of dosing adjustments to make sure it works well. This one has kind of become a little historic at this point. This has been available in the past, but there are issues with it and issues with availability that make it difficult for people to use. So what this is a little tablet that goes into the urinary tract. And you can see that schematic in the bottom here that the guy kind of slides this thing into their urinary channel, the urethra, and they deposit this very tiny pill. It's like the tip of a pen, really small, and it dissolves in there and causes an erection. So it's kind of like the material that's in the shot, except you don't give it as a shot. So that's an advantage. It avoids the use of injection. That's nice. It's very safe. Also, no side effects throughout the body, and you don't get the long-lasting erections or anything. But the problem is that it hurts. About a third of guys get pain. That can be mild, that can be significant. Definitely does not work as well as the injections. Again, have to have good dexterity. It can be quite expensive. When it is available, which is uncommon, it's about $25 to $40 per pill. So that's crazy expensive, the most expensive way you go about treating. And really, it's hard to get these days. So we don't really have many patients, if any, on this at this time. So switching from medications toward implants. This cartoon here on the side shows the simplest kind of implant, which is a malleable implant. So you can see that if you kind of look at the penis in cross-section, there's like a rod. There's actually two rods that go within the penis, and that rod can bend. So if a guy, let's say, has poor hand function or really wants no other mechanical aspects, they can put this in. It's very simple surgically. They can point, so they have a good erection. It's nice and firm. And then when they're done, they can sort of conceal themselves by pushing it out of the way. But it doesn't really go down, so it does stay firm. So it can show through clothes. That can be kind of embarrassing or even uncomfortable for guys. So while we do use these are not the ones we use most of. That's just a picture of what they look like outside of the body. They're just these rods. Okay, so what's much more common are inflatable implants, and the one I'm going to be kind of focusing on is the one on the bottom here, which is the one that's most commonly used in the United States. These are inflatable. So again, inside the penis, and you can see on this picture that the penis has an external element. That's what you can see, but it extends way into the body. And these implants kind of occupy that space, and they have very good stability because they go way into the body. Now they're attached by tubes to a pump, which is in the scrotum, like a third testicle. And this device is about the size of my thumb. And then you can see there's a balloon at the top, and that's tucked into the abdomen. The patient doesn't see or feel that one. And so when the patient wants to use it, they transfer fluid using this pump into the cylinders, they get a good erection. When they're done, they hit this little button you see there, and it all goes away. So these are easy to use once you get the hang of it. You look totally normal. The guy just looks like a normal person. You wouldn't be able to tell they have these. When they're down, they look totally down. So you could be at the gym in the locker room or wear whatever clothes you want, no, whatever, no. And when it's firm, it's totally firm. So that's all nice. So from a pro point of view, these have the highest satisfaction. I'm going to show this kind of on the next slide about the different ways one can treat this, but the implants really do blow the rest out of the water. Now, on average, they last about 10 to 15 years. These are mechanical devices, and so eventually they break, just like a knee replacement or a hip replacement or anything else you have. But 10 to 15 years is quite good lifetime. Spontaneity is amazing. They look very discreet, normal appearance. You have total control over the longevity, and your sensation doesn't get worse. You can still have orgasms, all that stuff, if you were capable of it before the procedure. We have lots and lots of clinical data because these have been around since the 70s. And so we have a ton of data on these over the many years. So this is a slide that tries to show the differences in satisfaction with the different treatments. So you can see that the medication, as I mentioned, is about 50%, injection about 40%, and the implant 90-some%. So that is a big difference. And it's for all the reasons I mentioned, the spontaneity and that it's discreet and easy to use and so forth. So what are the downsides of this thing? Well, number one is, of course, if you put this in the penis, then you don't have natural erections anymore. Now, we would never do this in someone who had natural erections, but that is, of course, something you need to know about. Now, if there's an infection, that's a big deal. The infection rates are very low. If we compare this to a hip replacement or a knee replacement, which are about 1% to 2%, penile implants are less than 1% in our series. And that's very good. But if they happen, often the device will have to be removed, at least temporarily, to clear the infection. I put cost with a question mark because it depends. Certain insurances always pay for these, like Medicare. Private insurers, it's sort of 50-50 depending on the plan. And for people who don't have insurance, they're relatively expensive. We try to offer good prices for these things, and Utah is actually one of the cheaper states to get them, which is good, but it's still costly. I say it may cause the penis to get shorter because it depends on what the patient does afterwards. If you just put one of these in, because the device can't go literally out to the end of the penis because it would be too painful for the partner, the penis would be shorter, but you have kind of homework you do afterwards that gets you back to your original size when you put it in. There can be lasting pain in patients, let's say, who have diabetes, who have neuropathy. Pain can be a problem. And mechanical failure, as I mentioned, they don't last forever because they will break at some point. I mean, if you have a nice car and you leave it in your garage, it'll last a long time. But if you take it out and zip it around, eventually you'll have to change the tires and other things. Okay, so why don't people like these things? Well, one is sort of the loss of penile length, which turns out to be more about what they remember their penis like back in the day. So I show this picture here. There's this guy, riding his bike with this giant penis. He's so happy and he wants what everyone wants, the middle, the big organ. But this is what a lot of my patients look like in the right. I mean, they've gained a lot of weight since they were younger. And they say, oh, but I seem to remember my penis was this big. But of course, part of that is just terrible memory. But part of that is that life has happened to them. They haven't been having erections. And so they get atrophy and size loss. They've gained weight and their belly sort of starts to eat their penis, as it were. And so they lose size that way. So if they get in their head that what a prosthesis does is make them bigger, well, that's not what it's for. It's there to restore function and restore the ability for intimacy, but it's not a size enlarger. And that's really important to remember. So summary of this part of the talk: erectile dysfunction is common. It's not just all in your head. It's associated with lots of medical conditions. It's totally treatable, and there's really no reason to suffer, especially in silence. Okay, so I'm going to switch gears here, and we're going to talk about urinary incontinence. This is more related for the guy who's had their prostate out. So those of you who are listening who have diabetes or other issues, you can sort of tune out for a second here. But what is incontinence? Well, that's the loss of urine that's involuntary. That's because of either a bladder problem or a sphincter problem. Now, there's really two main types, but you can also have mixed. Stress incontinence is the leakage you get with activity. So you cough, you sneeze, you lift, you do something, and you get little spurts that come out because the muscle that is normally there to hold in the urine is not functioning well. There's also such a thing as urge incontinence, where you say, oh, I got to go, and you cannot suppress it. When you got to go, you got to go. You drop everything you have, and it starts happening even on the way there. And of course, as I mentioned, you can have a little bit of both. Is this common? Yes, it's insanely common. There are lots and lots of men all over the world who have problems with urinary control for lots of different reasons. After prostate surgery, meaning removal of the prostate from cancer, incontinence is pretty high. I think you can see this number is all over the place, but most people have incontinence, at least at first, and about 10% of men over time will have bothersome enough incontinence they want something done about it. So why should we treat it? This seems obvious, right? No one likes to be leaky. It's very embarrassing. It makes people feel terrible about themselves. They isolate themselves. They get very angry. They get depressed. It's just a terrible deal. They want to return to their normal lifestyle, regain their dignity. Obviously, it's hard to be intimate if you're leaking urine, and it really is a huge quality of life issue. How do we treat it? Well, there's a bunch of ways. You could use a pad or diaper. That's not always very, that's not something people like to do, and it gets a little expensive after a while. There are some medications that work, at least for urge incontinence, and there are also devices and surgery. So the medications work okay for urge incontinence. They're not great, but they work okay. But there are no medications that are approved that work for stress incontinence, none at all. So pills do not work for that. There are devices. You could put a catheter in, something that's inside your body. Very high risk of infection. I mean, you could say 100% of guys get infection. There are also external catheters. You can think about like a condom, which has a tube on it. They're hard to fit. They often don't stay on. So some people like them, some people don't. There's clamps. You can see an example of one there on the side. They are pretty easy to use, but you have to move them around all the time or they'll destroy the skin. And they're overall just sort of inconvenient. So while they work, satisfaction is not that great with those. Now, of course, you could do behavior modification. You could stop drinking fluid, then you wouldn't need to pee. But that doesn't work that well. The urine becomes very concentrated. It actually smells more, and it's just not good for the health in general. You could also pee really frequently and try to make sure the bladder is really empty. That can be super inconvenient and doesn't always work, but it's an option. You do want to avoid things that stimulate the bladder. Everything you eat or drink or bring in eventually ends up in your bladder. So things like caffeine, alcohol, bladder stimulants like hot foods, and there's a huge list of things that can do this. They can make you want to pee more. And if you have stress incontinence, you could try to avoid activity that uses the abdominal muscles, but that's basically everything. So that's not a realistic way to do it. Bulking agents. People have tried to put in materials that kind of push the urethra together so it doesn't have as much space to leak. That works terribly. It's safe, that's good. It's outpatient surgery, that's good. Disadvantage is it works awful, 20% maybe, and you always need repeated treatment. So we basically don't offer this because it works so badly. Slings. Slings for men are kind of based on what's been used for women for many, many years, very successfully. A question we get a lot about this is people look at this and say, well, that looks like mesh. I've heard mesh is terrible. There have been problems with mesh, but not this kind of mesh. There are different mesh systems that are used in women that have led to lawsuits and all sorts of problems in the past, but this is not related to that at all. So what a sling does, it kind of restores the support under the urethra. The urethra in this case is the gray object in the middle there surrounded by muscle. That's the pink part. So it restores the support. The guy doesn't need to do anything. They just pee normally, and they can really improve their control. It's an outpatient kind of procedure, but it really only works well for the guy who doesn't have that bad of leakage. Maybe 1 to 3 pads. They have generally okay control, but not as much as they'd like. The gold standard is what's called an artificial sphincter. And if you look at this diagram, you can see that part that goes around the urethra. It looks kind of like a blood pressure cuff. So most of the time it's closed, very, very gently closed, but it's closed. And then when they use this pump that's in the scrotum, that cuff opens up and they can pee. And then on its own, controlled by a little balloon you can see there, it closes So after about a minute or so, they go back to being dry. These work great. People love them. Greater than 90% satisfaction, just really tremendous, life-changing, really. And again, around since the 70s, so we have loads of data. The risks pretty much the same as the penile implant. Mechanical failure, risk of infection, need for surgery if this thing fails. So with that, I'm actually done with the slides. So I'm going to stop my sharing, and I'm hoping we have some questions. Okay, so anyone have any questions?